Again. Awesome. So Dr. Boender and I are going to talk with you all a little bit about perinatal cannabis use this afternoon. So we're hoping to, by the end of today's talk, for you all to be able to understand and explain at least like the basics about cannabinoids, understand some pregnancy-related outcomes and some outcomes related to chest and breastfeeding, and then be able to describe some of the treatment options and challenges in care delivery for our patients who are using cannabis in pregnancy and postpartum. So, just like a really brief background. You can go to the next slide. Cannabis or marijuana is harvested from the leaves and flowers of the hemp plant. It's actually encouraged to use cannabis, that term, rather than marijuana for a few different reasons. So we'll be using that today. And THC is the active ingredient that's found throughout the plant. It's the most commonly used substance in the United States, and it's one of the most commonly used substances during the perinatal period. And we'll talk about like the increase in use and the increase in daily and frequent use as well in the last few number of years. So generally speaking, THC acts on the endocannabinoid system, and delta 9 is the primary psychoactive kind of component, metabolite of cannabis. There are a number of different types of endocannabinoid or cannabinoids, but this is the primary one. This one is illegal. There, for instance, I know like Delta 8 is one that comes up a lot nowadays because it's sold in like gas stations and at some other stores in states that have not yet legalized Delta 9 THC. But essentially, it acts on throughout the body. Adults have endocannabinoid receptors located throughout. And here is just a quick overview of the states that have legalized cannabis for recreation or medical purposes. So 38 in total. But importantly, this is still not legal at the federal level. So it's not legal in South Carolina either, but for all of those other states, it still is not legal at the federal level. So there are, I'm not going to go into all of the nitty-gritty with the receptors, but essentially, the receptors are found primarily in the central nervous system, especially the CB1R receptors. And there's some kind of the way that it works is it inhibits the release of a bunch of different neurotransmitters. And so that changes kind of how your body is interacting with your world and vice versa. And you can see how kind of spread out throughout the body, diffuse throughout the body, these receptors are. And I think that this is also really important too, to note that this is an adult and the location of the adult receptors, because these do not start out kind of diffuse throughout the body from conception. And so that's kind of an important factor to keep in mind as we go through this talk. And so I think, Dr. Boonder, you're going to take it from here. You're muted.
Okay, I'll get this restarted. Sorry about that.
There you
So,
go.
cannabis use during pregnancy, approximately 18% or one in six pregnant women will use cannabis while pregnant. The rates are increasing, and it's similar to the increasing rates within the general public. There is a lot of confusion around safety in pregnancy and postpartum. And so I'll go through that a little bit, why some of that confusion is there. But the percentage of women who reported that there was no risk of harm has increased over time as the rate of use has increased as well. And so this is just some data from SAMHSA that shows the increased rates of use both in the pregnant and the not pregnant population, and then also daily or almost daily marijuana use increased rates as well over time. And so when we look at pregnancy and breastfeeding, pregnancy, cannabis does readily cross the placenta. It's highly lipophilic. The older data showed receptors were found as early as 14 weeks, but some of the newer data shows that it's even sooner at 5-6 weeks. And so the receptors are present in the fetus at a very early time. And so that's the question, is if we're using a substance that can act on those receptors and it's crossing the placenta, what kind of outcome or what changes could that do? And so we'll go over that. And then breastfeeding as well, it can accumulate in breast milk and remains there for extended period of time. So looking at pregnancy outcomes themselves, part of the reason I think for the confusion of safety in pregnancy is some of the older data showed potential adverse outcomes, but the association maybe was not quite as strong. But it's really important when you look at any data that when it comes to cannabinoids, is what year was the data published. So this is a study from 2016 where they looked at DEA confiscated cannabis and the percentage of THC within that. And you can see from 1995 to 2014, that steadily rose from 4% to 12%. This is within the same study or the same article, but I know it's a lot to look at, but things to really pay attention to, just to compare, in 1995 on that top line, the percentage of THC less than 3% was 28% of the samples. And if you go all the way to the bottom to 2014, it was only 7%. Whereas if you go over to the last main column, the percent of THC over 12%, in 1995, less than 1% of samples had THC concentrations more than 12%. If you went on to 2014, 41% of samples had THC concentrations at 12%. So looking at yet another study that looked out further, the THC percentages have continued to rise. And so in 2022, the study showed THC concentrations of 16%. So when looking at data, if we look, this is the committee opinion, the reference section from the committee opinion on marijuana use during pregnancy that came out in 2017 and then was reaffirmed in 2021. I underlined when the different studies were published, and a lot of the data we were using at that point came from when THC concentrations were much lower. So it's really important, if anybody is citing data on THC outcomes, that you look at when that data came from, because it's not a fair comparison when looking at the differences. This was from ACOG's committee opinion that we'll talk. We have a little bit of updates, but it also is important whenever you're looking at data in general with THC or cannabinoids in pregnancy, that it's really hard for us to determine causal effects. And there's a few reasons for this. One, polysubstance use. Many individuals who use cannabis in pregnancy use other substances, including tobacco, which we know has negative outcomes in pregnancy, or other substances as well. There might also be other confounding exposures. So some studies have showed the carcinogens in THC products or cannabinoid products can be higher than in tobacco products. And so there's other potential exposures within those substances. Also, there's confounding factors. And so individuals who use cannabis during pregnancy tend to be more underweight, lower education levels, lower income, less folic acid use compared to their comparison groups. There also can be recalled bias and unknown potency as well. And so it can be hard to do studies to determine causal effects, but we do have some more recent publications that show more of an effect. So this is from JAMA 2024, and it looked at pregnancy outcomes. It was a population-based retrospective cohort, and exposure was considered a positive validated screen or positive urine drug screen. And 6.3% of the population was positive. And you can see an increase, the chart on the right, increase in gestational hypertension, preeclampsia, abnormal weight gains, and then also placental abruption. The American Journal of Perinatology had a systematic review and meta-analysis in 2024. The quality of evidence was low in this meta-analysis, but it did show increased rates of low birth weight, preterm birth, small for gestational age. And then this was a manuscript that was in the American Journal of Obstetrics and Gynecology in 22 that looked at a variety of different studies and suggested changes in hormonal factors for women, and then also in pregnancy, increased NICU admissions, small for gestational age, placental abruption, low APGARs, infant death, and then other long-term effects as well. And so ACOG did come out with a new consensus in 2025, and it updates and has more updated data than what the previous studies had, or the previous committee opinion they had, which I think is good. And this replaces that committee opinion 722. Within this, they also really focus on how to approach and educate patients as well, so that we can have more informed conversations and we can with patients, and focus on what are the actual outcomes, not just what are the legal aspects of it. But the newer data shows that there is associations with cannabis use in pregnancy of low birth weights or SGA neonates, NICU admissions, increased perinatal mortality, altered arousal patterns and regulation in the first month of life for the neonate, and then long-term association with ADHD, behavioral changes, memory challenges, intellectual disabilities, and other executive function, and then also increased risk for substance use disorder, psychiatric disorder, and offspring as well. And so at the end, I know this is really small, but you can find this on ACOG's website within that clinical consensus. But they really focus, OBGYNs and other healthcare professionals who work with pregnant women should be knowledgeable and able to educate pregnant women and families about potential risks with cannabis use in pregnancy and lactation. And also be aware of, part of that is being aware of how have studies changed over time, and why might studies from the 70s and 80s be different than more recent studies with the percent THC that we find that individuals are using. And then also we should be educating patients that there's no medical indication for cannabis in pregnancy or during pregnancy. A lot of the reasons that individuals will continue using cannabis are things that we can treat with other modalities. And so anxiety, nausea, things like that. So it's important to pay attention to that. And we'll talk about that in a little bit as well. Providers should be aware of the legal consequences. And we should also be actively working to address the inequities that are within our system. We should have universal screening by validated screening, but very specifically, they know that biological testing should not be used as the screening assessment for cannabis use. And we should advise for cessation of cannabis use in pregnancy and lactation. But, and we'll get to this in a bit, it's not a contraindication for lactation. And we may use a variety of different tools to help patients with decreasing or cessation of cannabis use in pregnancy. And we'll get into that in a little bit as well. So looking specifically at cannabis use and lactation, I used a few different organizations and their statements on this. This is from ACOG's recent article as well. But again, just a reminder, cannabinoids are lipophilic. And so breast tissue has fatty tissue, and milk has fat in it as well. So, and then cannabis crosses a blood-brain barrier. So THC is excreted and can concentrate in breast milk. And so because of this, the fetal THC concentrations can get pretty high in breast milk. And one of the studies they listed, the fetal THC concentration is about 10% of the maternal concentration in that study. And the risks of adverse outcomes increase in a dose-dependent fashion. And so it's important, their takeaway from that was considering our limited data on safety with breastfeeding, the use of cannabinoids during pregnancy is discouraged. However, given the benefits of breastfeeding, ACOG also states it's not a contraindication to breastfeed, and lactation should still be encouraged regardless of cannabis use. But as providers, it is important for us to be educating our patients on how cannabinoids act, how they can cross into breast milk, and also the limited data, safety data profile that we have. This is the American Academy of Breastfeeding Medicine, their clinical protocol from 2023. I put in two of their charts that I think are really helpful. The bottom one is one that I will talk to patients about, because sometimes I think a lot of individuals don't realize how long the half-life of cannabis or THC is. And so we'll talk to patients if they will ask, can I have a glass of wine with supper? Well, the half-life is much shorter. And so we know that after a few hours, that concentration in breast milk is low, even though the relative infant dose is higher. However, the half-life of cannabis or THC is so long that it stores in breast milk for a long period of time. And so that's one of the big things with breastfeeding is even if only occasionally using, it can store in breast milk for a long amount of time. They recommend, the Academy of Breastfeeding Medicine recommends cessation or reduction of cannabis during lactation. For the infant, there's possible neurodevelopmental effects as a result of use while breastfeeding. It does change breast milk composition. And then the consideration is for individuals who continue to use cannabis and wish to breastfeed. It's a shared decision-making process, but it's important we discuss the risks and the benefits. And then the Academy of Pediatrics has a similar statement within their clinical report. They suggest encouraging breastfeeding, but strongly encourage abstaining from marijuana and other substances while breastfeeding. But again, it's not listed as a contraindication within their recommendations. Now, one of the things that we have mentioned is important, and ACOG had stated this as well, it's important that providers be aware of the legal aspects of cannabis use in pregnancy. This is from the South Carolina State House website with where it lists what our laws are, but Section 63.7/1660 states that, and this is the services with removal, or this is for involving CPS, is it's presumed that a newborn child is abused or neglected as defined in Section 63.720, and they cannot be protected from further harm without being removed from the custody of the mother infant upon proof that, and A is a blood or urine test of the child at birth or blood or urine test of the mother at birth shows a presence of any amount of controlled substance or metabolite of controlled substance, unless the presence of substance or metabolite is a result of medical treatment. And so it's really important to recognize that having positive urine drug screen for any substance, unless it was prescribed, is one of the mandated reporting. But this is something that's important for any provider to be aware of as well. As we've had many studies over the past 30 years that have shown that when doing random urine drug screens, individuals and women of color are significantly more likely to be tested. And this is just a more recent publication from 2024, but there are many publications going back that have shown similar things. So in this study, the odds ratio was over 4 that Black women were more likely to be tested compared to their white counterparts. However, when they test everybody, the white women who presented for birthing admission were more likely to test positive. And so despite this, this is an example of racism within medicine where we will often test individuals and women of color, even though the results are less likely to be positive. And it has very serious implications with involvement of DSS or having a child removed from a family. So as a system and as providers, this is something that we really need to be mindful of and be paying attention to. And that's something that ACOG supports as well. This is the end of the first section where we can stop and answer questions. I'm going to leave this screen so I can